Good morning. We are back. Dave Kittle with me. I'm Tony Maritato. This is PT Breakfast Club. Dave, how's your day going so far?
Tony, I'm feeling great. Day is going wonderful so far. How are you?
Good. Tell me, we talked about this a long time ago. I used to run every morning. That was part of my routine. Like I'd wake up, I'd make coffee for my wife and I. Oop, hang on, I got my playback. And I would get the kids on the bus or my wife would take them to school and I'd go for a run. Now I'm going into the clinic every day. I am struggling to get any kind of workout in. Running, lifting, like I went from 7 days a week down to like 2 days if on a good week. What are you doing these days fitness wise?
I have a whole bunch of weights in my garage, barbell, plate, weighted plates, the adjustable Bowflex dumbbells, and I also with baseball because I played college baseball. I still play weekend men's baseball in the spring and the summer, so I hit off the tee in there, and I go in there almost every day. And then the days that I don't, I go for a run. So like last week when it was like 19 degrees on Tuesday or something, I went out for a 5 mile run and it was glorious. There was only two runners out there along the water. It was me and some other crazy person. So a little bit of yoga actually this morning with my baseball buddies, three or four of us, we do Zoom yoga for like
Wow.
20, 30 minutes, like one day a week. So I mean, I have to get it in.
Yeah.
I'll go crazy. I'll make it just has to happen. It just has to happen. So I don't really schedule it. It's not really like on the calendar always. Um, but it has to happen.
Do you have any issues? You're probably too young for this. I used to like I could work out whenever I wanted. Doesn't matter when I eat, when I don't eat, whatever. Now it's like I love to work out in the morning because I don't usually eat any food till like noon or 1 o'clock. Now I'm in the clinic till noon. I come home. Now I've got a decision to make. If I eat, I'm done. I'm fried. I can't go for a run. I generally have really good blood sugar. But if I eat and then I try to go work out, my sugar's all over the place. Do you care? Does it bother you at all?
I mean, yeah, I if I'm gonna go run 4, 5, 6, whatever miles, I'll usually do it in the morning, and it's when I haven't had anything to eat yet. So it's like maybe I've had some water or some electrolyte drink, maybe a few crackers, just like. But otherwise, and also with meals, like I can't have a big meal and then work out. I have to have like a meal 2 or 3 hours before, and then leading up to a workout, I'm chewing gum which somehow I don't know, I don't have any science behind it, but it like feels like it helps with digestion or it helps with like I don't know what it is, but it like primes me for working out. I chew gum while working out, lifting weights and all that, and hitting or whatever I'm doing, or running. I'm chewing gum, so I don't know, but that works for me.
Nice. All right. So let's get into today's topic. I pulled up an article. I'm going to share it on the screen. This came from APTA. Pretty cool article. It's publicly accessible, so you guys can go find it. I'll actually put the link in the chat so you guys have it available. And they're looking at, hey, David's with us. Good morning, David. They're looking at how do physicians perceive physical therapy. So they've been running this study 2007, 2016, 2021. So it's been going on over 17 years. And there are some really interesting stats that I think we can look at. I'm going to assume there are certain biases in this, like everything. But that being said, okay, so 95% of PCPs view physical therapy very positively. They trust the care a physical therapist provides. I would hope so. 86% of them refer to physical therapy frequently. That's kind of shocking considering the number of referrals we see and the number of patients that actually go to therapy. But why do you think, Dave, most people, now not your population, but the general population, why are they not going to therapy when they have a referral in their hand?
They probably think it's going to be too much work for them, whether it's calling in, booking, scheduling, driving to your brick and mortar office. Um, there's some of that. I think also some is like people don't know what physical therapy is, or what type that they need, or um, they I think it's just so many factors. I don't think it's just that. I don't think it's just like people don't know what physical therapy is, or if they go and call 5 different offices nearby, it's going to be 5 different phone calls. And then if you're probably not going to, but if you went and did one visit at all 5 offices, typically it could vary uh almost dramatically. Like, it could be
Yeah.
one-on-one, it could be a busy office where a therapist is seeing 5 patients at the same time per hour, or something in the middle that might be like ideal for, and like all those are ideal for some people. um I don't know, what are the other factors that I didn't mention?
You nailed it. We'll talk about it. I'm going to say, and I'm going to ask you too. I get like, I don't see the doc probably more than once every 5 to 10 years. But even when I do, I almost always get a referral on my hand for something, and I never go. I never go. Like, it's just, it's not something that's important to me. Unless I'm really like, I'm going for something. Thankfully, I've been healthy. I've been fortunate. If I'm going for something, some sort of test, I want a blood test. I'll get a referral. I'm going to go get the blood test, but I'm going to the doctor to get the referral for the blood test. Other than that, I think it's the same thing. They're like, my shoulder hurts. You want me to go work out? You want me to go see a personal trainer? What are you talking about? I think that's a big part of it. Real quick, it said 98% of docs said that they referred to physical therapy in the last 6 months. 96 agree that collaboration with physical therapy is beneficial for both them and the patient. So this was the part that I thought was really interesting. Challenges to making the referrals. So it said 61% of PCPs believe that patient cost is a reason that their peers, not them, but their peers, might be hesitant to refer their patients to physical therapy. I think,
So
like,
that's an assumption. That would be a physician saying, I think my physician colleagues in that state or across the country or whatever would be a little less reluctant, or less likely to refer, because they don't want their patients to incur out-of-pocket costs. Am I reading this properly?
that's the way I understand it. They're not saying they use this. They're not hesitant. They're saying their peers are hesitant.
Which, but just
Yeah,
my thoughts on this is that is, I don't, like, that's just an assumption, or I mean, it's ridiculous. Like, I know that people are spenders. I've said it a million times on the show. You go into someone's home that says, I can't afford healthcare. I can't, for a lot of people, not everyone, but a lot of people, you go into any person, any neighbor's house that says, hey, we're not doing well, we're struggling financially, whatever. You go in their house, there's Amazon and Walmart boxes everywhere.
yeah.
Right. So, like, how are we making these assumptions on cost? Again, it's, some people truly can't afford it, and I get it. And that's, maybe you do telehealth or Medicaid or whatever. But I don't understand why this would even be an assumption. Like, I think it's ridiculous.
I think it's they have heard, just like us, they've heard from so many patients, I can't afford this, I can't pay for this. Everything is this level of scarcity that they can't do it. But it's just, you become brainwashed, you become desensitized to it, and you just think, okay, this is everybody. Well, it's not, and we know it's not. But these are the perceptions that kind of lead reality right now. 52% believe that patients don't want to try physical therapy, which I agree with. I think most individuals, most laypersons, if you say, I've got this orthopedic pain somewhere, I need you to go to physical therapy, they're thinking either physical therapy is for brain injuries, for strokes, I don't have any of those problems, or they're thinking PT stands for personal trainer and I don't want to work out. You're not going to talk somebody into exercising when they don't already exercise and they don't value exercise. I share this example. My mother-in-law, love her to death, 90 years old, had an injury. She is the type of woman that will carry 3 gallons of water in each hand across the yard, an acre of grass, to water her plants. If I give her a 3-pound dumbbell, she'll tell me it's too heavy. It's so much about the context. She doesn't want to sit there and pedal a bike that's going nowhere. She wants to do things. She'll stand in the kitchen baking cookies for the kids for 3 hours. She will not get on a treadmill for 2 minutes. So yeah, I agree. patients don't want to do physical therapy because of their preconceived notion of what physical therapy is. What has been your experience?
Yeah, I mean, that's a huge problem in physical therapy. Like if you're in a hospital, right? Like let's say you had, I don't know, like appendicitis, or you went in the hospital for some I don't know, COVID, whatever it is. And a physical therapist comes in and they just like walk you around the room or walk you down the hallway, and then like that person for the rest of their lives thinks that's what physical therapy is, if they don't have another experience, or if they don't see a YouTube video, a TikTok video, Instagram video, whatever. That is the challenge. It's like there's the inpatient, there's the home health, there's the pediatrics, there's the neurological, the, like you said, stroke, traumatic brain injury rehab. Then there's outpatient physical therapy or mobile physical therapy, and there, therapists that do dry needling and shockwave and stim pod and spinal manipulation and cracking backs and all that, and a million things in between, right? So that is a that is ultimately the biggest challenge, which is there's so much variability in physical therapy that there's like no real clear definition. So consumers have all these different perceived notions and definitions about what it is. And when those people are like, well, I don't want that, or I don't need that, then it doesn't happen. I mean, a lot of times we're doing home visits for someone, and if it's like a geriatric client, or if it's gait, balance, neurological, whatever, there could be a family member or the spouse that is in better functional physical condition, and they're doing outpatient physical therapy for their back pain nearby. And we say to them like, hey, like I like their perception is we're coming in to help the spouse, the family member, or whatever, with like gait or balance or whatever, and they don't see or think or believe, or maybe we're not conveying it well enough, maybe we're not communicating it well enough, that that same physical therapist treating your spouse or family member for stroke rehab can also help you with your back pain and sciatica. Our therapist can do both, but not a lot of physical therapists can do both. I think they're kind of like it's one or the other. What do you think?
Yeah, no, I agree. Now, this is where we get into specialization, and this is where I would say I wouldn't want to do both. I wouldn't want, my therapist to do both. Yes, they're capable. They have the background and the skill set, but I want to pick one niche, one target. Um, Now, this goes on to say 29% of PCPs believe their physical therapy would be too time consuming. Another 20% identified access to local physical therapists as a concern. So we know there's long wait lists. That's not a surprise to anyone. I do say, look, you're making a commitment here. And this has been a topic that I actually wanted to discuss. Let me take this off the screen for a second and let me ask you about this, because you're going to help me think of this in my own head. So it's too time consuming. How do we start?
Ridiculous. It's ridiculous. But go
How
ahead.
do we start the conversation around that? Because I think a lot of the drop off happens when, yeah. So for me, it's probably an average of 20 minutes for the patient to get to my clinic. Then before that, probably another 20 minutes of getting ready and showering and dressing and doing all these things. Then you're going to be at the clinic, let's say an hour. I don't like hour sessions, but let's say we're doing hour sessions. Then it's going to be another 20 minutes to get home. And then, maybe another shower if you got sweaty and stuff like that. You're talking about a 2-hour time commitment here. How do I prepare somebody on the evaluation? Do I start the conversation right then and there to say, look, this is a commitment to yourself, not to me, not to your doctor, not to anybody else. This is a commitment to yourself. We need to find the motivation for you to want to make this change, to want to invest this time. And I always say, everybody's schedule is full. Even if those 2 hours would have been spent watching Netflix, that is still something that is filling that time that has to be removed so that we create a vacuum to suck you into the workout program, the home exercise program, the things that you need to do to make these changes. What are you thinking?
Yes, exactly. At the evaluation, even on the first phone call before they come in, like this is what we're trying to do. And we're trying to connect, like, so if I'm on the phone with you, Tony, and I'm like, so like what do you have going on and all that, what is it preventing you from doing, how does that make you feel? So for you, like if you couldn't run, you couldn't drop your kids off, drive them around, you couldn't do whatever the things are that you care about, I have to find that out. I got to pull that out of you at the first phone call, or at the very latest the evaluation, the first encounter. I coach my therapist on this. We need to identify like what is the thing they care about. They don't care about physical therapy versus massage versus chiropractic versus dry needling, acupuncture, or whatever. They care about themselves. Like what is the thing that they want to do? You got to find that out. So if it was the prospective patient is your mother-in-law with walking across the 1 acre with all these water jugs to water plants or whatever, like you gotta tap into that and ask questions that are around those things that that person loves to do, that lights them up, that gives them energy and all that. And then you say, oh yeah, like we don't, I'm not going to get into the nitty gritty of the treatment that we offer. I'm going to say we help people like this thing that you're talking about getting back to, and it might be this type of a timeline and all that, but again, you would be investing in your health and wellness so that you can get back to doing those things that you want to do. The whole phone call or the in-person evaluation like needs to be focused around what that person cares about. They don't care about the shoulder joint mobilization, the thoracic mobilization, of kinesio tape, like whatever it is. Those are the things you're going to do for them. That's the conduit to get them towards their goal. If you do all the talking about the things that they care about, then they start to think, oh, like this place is different. They get me. They kind of understand me. They lower their guard. Now they're more likely to say or to themselves, it absolutely makes time for me to invest my time, and now and then cost. Like it makes sense for me to spend this money that otherwise like I'd be spending on whatever or not using, um, because the physical therapy office or the physical therapist or whoever understands me, understands you, understands the patient or client. That's the main focus there.
So at that point, you got the buy-in. They're like fired up, they're peak enthusiasm. Now do you take time, just like you would for an exercise, you teach them the nuances and you teach them all the little technique aspects. Do you take time at that point within, I think it's probably the evaluation, to say, okay, how are we going to make this work? Here's the plan. This is what I'm prescribing. How are we going to find the time in your schedule to make this happen? What are you going to eliminate? Because they have to eliminate something. Where can we find 2 hours, 3 days a week, 15 minutes the other days a week? Do you go that granular I don't, I wish I did. I think I need to. But do you get into it that deeply to prepare them for success at that level?
We right now we don't go that deep. If it's like for the evaluation, right? If it's with you, Tony, I would be saying like, hey, you have whatever this back pain situation, whatever it is. Um, Based off of my plan of care, let's say I do the evaluation. I think, hey, this is going to be, I'm going to get you there. I'm going to get you to your goal. It's going to take 12 visits. It's most likely going to be 6 weeks, 2 times a week for 6 weeks. You have to do so. Here's some of the things you got to do on your own. I'm going to give you some drills, whatever. All those drills are focusing on the thing that you want to get back to: running daily, dropping your kids off, all that, coaching, whatever it is, being a physical therapist, so you can treat your patients with your new shockwave device, whatever it is. Um, I'll then say like, so here's the game plan. Like, do you have anything, Tony, in the next 6 weeks? Do you have anything with work, with travel? You got a cruise coming up, you got a vacation coming up, you have PTA, Rotary, you got family commitments, you got volunteer activities, whatever. Do you have anything that's going to get in the way of that plan of care, like that game plan? I don't say plan of care. We usually say game plan or treatment plan. Um, do you have anything that's going to be getting in the way of that? Because if so, like then either we do more visits before you go away, or we say, hey, this is going to be a game plan that's now 8 weeks. It's going to be 8 weeks, but because we had a little bit of disruption in the middle. Do you have anything that's going to be work related or personal, related, that's going to get in the way of this potential game plan in the next 6 weeks? Tony
Yeah.
says, Tony says no. And they're like, all right, so great. So this would be the game plan. You're gonna book out these visits, and here's some simple things you're gonna do at home. But this is the game plan. I've seen this a ton. If you stay on track with everything, we do what we have to do. We follow the game plan. We're gonna get you back to the thing you want to be doing. But no, we don't go too granular of like you're cutting, like you need to come in 2 days a week, Tuesdays and Thursdays at, I don't know, whatever works for you, 5 p.m. So like what do you usually do then? Like, are you usually working, whatever? I don't get into that too much. I could see how that would be a benefit though.
Yeah, I think so. Scott, he's here. He said, great topic. You're both spot on. Looks like you stumbled upon some great content for social media. I agree. Like these kinds of things, you know, why are people failing their physical therapy? Why are they falling off? Like, I think we passed the official day where people made their New Year's resolutions and then quit already. But these are the kinds of things, you know, how I think people know they need to exercise more. They need to eat better. They need to do these things. They probably even know what to do. They don't know how to get themselves to do it. And so
The
it's,
accountability.
yeah, this conversation absolutely deals with accountability, emotions. You know, there's something going on inside. I love James Clear and Tiny Habits and all of those pieces of content that help me build a framework to kind of lay out the path.
Another thing that this article, I'm sure it doesn't even mention at all, but when you were just talking about like the buy-in, I think a huge thing that's, I mean, sometimes it's talked about, but it's a little more overlooked, which is the confidence of the healthcare provider. So whether it's the office, like when you're calling in, how does that call go? And then how does that transition to booking the evaluation? And then you're getting evaluated by one of my therapists, or you're getting evaluated by Tony Maritato or one of his therapists or whatever. The focus around that evaluation, what's said, like we're kind of talking about, you know, booking out, and here's the game plan, here's what's going to get you better, and finding those emotional triggers and making the whole conversation about them. And but it's the reassurance or the certainty or the confidence that I always like to say, like, hey, and most of the time when someone's calling in, it's a lower leg surgery, it's a back pain, it's a sciatica, like it's something that we typically honestly evaluate and treat all the time. So a little bit more rare would be we had someone call in with like ankylosing spondylitis, but at the end of the day, like her main thing was like needing help with like strength, gait training, walking, balancing, right? So like that we evaluate and treat every day. So we say that on the phone, and my therapist need to continue to say that and convey that confidence and that certainty, so that that patient is like, it makes even more sense for them to carve out the time in their schedule, pay whatever the cost is, if they want to, of their own choosing, of their own volition. But the therapist with the confidence of like, hey, Tony, we got this. Like I see it all the time. It's common. Unfortunately, it's common because I know you're in a lot of pain or you're in a tough situation. So I get it. But this is something we see all the time. And very experienced in it. And here's some of the testimonials of people that have gone through this with this sciatica or what, you know, stroke or Parkinson's or whatever. Like we send them Google reviews, we like here's some social proof, here's some success stories and all that. But that confidence of what we can do for them, I think is part of the buy-in for them
Yeah.
to book out the visits and then attend all the visits.
Right. Right. Bo said Atomic Habits. Yeah. James Clear is Atomic Habits. BJ Fogg is Tiny Habits. Both great topics. Craig, he said, do we help with the goal setting as a primary focus to, quote, help them get better? Yeah, I think that's a huge aspect to it. That makes it personalized. That makes it about them. You know, the mechanism of achieving the goal, pretty much a commodity. Like this is where I go back to the science behind what we do. Anybody can get that anywhere. There's virtually no value left in the science. It's not hidden in textbooks anymore. But the mechanism, the way we get them there, that is what is unique to each of us, each of you. And I think that's where the real value is.
Craig's a Chiefs fan. Just want to say, Craig Lee, go Eagles for the Super Bowl. But let's keep it going. Stephen Dunn, what do you got?
Steven said, great combo. I can definitely be better with these conversations on the first visit. Yeah, this is just, look, guys, I've been in this world 25 years now. I am just now starting to think about these things. Like there's never been a time in the past 25 years that I wasn't trying to improve some element of the patient care experience. And I fully admit, like, I am not looking for more clinical knowledge. I don't think more clinical knowledge is going to bring me any better outcome than I can achieve right now with the knowledge I've accumulated. So now I'm going into these other areas where I think I can have a bigger impact, which is just like we handle objections in sales. What are the stumbling blocks that are going to make this patient fall off the schedule, even though they genuinely want to get better? And I think it's not understanding how to carve out the time, how to eliminate less important things on their schedule. If I can provide those tools and resources, we can get there. Craig said, good luck to your birds.
Thank you, Craig. Yeah, he and I were talking smack on Facebook because he's a Chiefs fan, but it's going to be good. It's going to be a good game. Going back to what you were just saying, and from Stephen Dunn's comment, Tony, um, the thing that you were just saying, like we don't need more clinical knowledge for the most part, and assuming you're established therapist, like most people watching the show, and I agree with that. A little maybe you'll push back, maybe you'll disagree, but I think the biggest reason why a lot of therapists, like, so even Stephen Dunn, who's been in practice for years, he's been a therapist for years, and we're all saying, like, hey, we need to maybe improve this. I think 5 years ago, 10 years ago, maybe even 15 years ago, when insurance was like either paying better, there was less cost of goods and rising costs and all that. um, I think it was easier then. Like you didn't have to be good at these skills. Now copays are higher, deductibles are higher. There's more payers where people are paying more out of pocket. Premiums are higher. There's more out of pocket services, and you have to be better. You have to do these things if you're trying to convey. Here's how we can help you. Here's what we're going to do. Here's how we're going to take you from here to here, from one side of the bridge to the other side of the bridge, and cover. Here's the cost, and the cost is maybe it's more, right? Like for us, like maybe it's more out of pocket. So it's like 15 years ago, therapists, practice owners didn't have to worry about this. It was just like people call in, do you take my insurance? Yep. Copay's $15 or 20 or whatever. And we get you scheduled. You come in. The resistance was low. There was no, barrier to entry. It was just like any patient was just calling the local therapy office, as long as they took their insurance. Now, places are dropping United Healthcare and other insurances, and you have to be better at all this because of the change with like costs and insurance and all that. Do you agree? Do you disagree?
Yeah, no, I totally agree. Like before, when a copay was $15 or most services were covered by insurance, who cares? It's like a free sample at Costco. If you don't like it, you spit it out. Nobody cared at that point. Now it's getting serious. I've got multiple patients on Medicare Advantage with $35, $45, $50 copays. Yeah, I better produce results, and it better be enjoyable. It better be delivered on a platter that they like. It can't just be what's most effective based on clinical research. Guys, we're going to wrap it up in about 5 minutes just because I've got some commitments, but I want to hit these last three things. Drivers referring to patients to physical therapy. So they said, number one, the PT's competence, experience, and reputation. I thought that was kind of interesting. I would assume we were cogs in a wheel. I would assume it doesn't matter who you send to, but I think now more than ever, social media, like you could be the celebrity PT in your community, no matter who or what else is going on. So yep. Competence, yeah, we got a minimum standard. Don't make my patients worse. Experience plays into it, but reputation, I think reputation is so powerful. What are your thoughts on that first option?
Yeah, so reputation, I think now could be in multiple ways. The old school traditional way is like word of mouth, and Tony Maritato, like he's been there forever. Go see Tony, go see Anthony Maritato, and then they go and they might see you, they might see somebody else, whatever. So reputation, word of mouth, whether right or wrong, followers on social media could be part of reputation. If someone's got a YouTube channel with like a ton of followers, like Total Therapy Solutions does on YouTube, that immediately lends itself to some social proof and credibility, right? So that's why, Tony, you have people flying in, driving in hours away to come see you. And I think you're more than humble enough to always kind of mention and say that, like, you're not necessarily like the best, and that person is probably driving by dozens of other therapists. I say the same thing. Like for us with advertising on Google and Facebook, like I don't think it's hard to grade it, but like I don't think we're necessarily like we might not be the best clinically in New York City, but if we pop up and they call us first and we wow them on that call, we wow them on the initial evaluation, they're going to stay with us sometimes for years. So reputation can take many forms, and we can certainly discuss it more.
Yeah. Number two, PT's willingness to collaborate and communicate with other providers. Another surprising one for me. I don't know a single surgeon or primary care doc or anybody with MD after their name in my community who genuinely wants to collaborate and communicate. Like, they're on such a tight timeline. They're so busy. They're so full. They don't have time to hear how Mrs. Jones is doing with her, post-op recovery. They just tell me, like, they want to know the absolute minimum that they need to know. Now, the one time they will reach out to me is when they're trying to get documentation to support a surgery or some further testing. Somebody from their office is calling my office asking me to send all of the treatment notes and all of the justification. But again, it's not the doc. He doesn't care. He just needs the approval from the insurance company. Are you actively collaborating and communicating with any referral sources like doctors?
One main one, a podiatrist where we've met up for food a couple times. We actually had like a double date. He brought one of his kids. We brought Davy Jr. This was like in, I think in December, at some place nearby, like a restaurant. So we went out for like a lunch on a Saturday, and then we also like when we were there, we are like, oh, you guys love sushi too. So like, all right, the next time we go out, we're gonna double date and we're gonna go to this place Fushimi nearby. We're gonna have sushi, And like the first time I paid, and then like the most recent time he paid, and he insisted on paying. So like next time I was like, all right, sushi's on me, or on it's on us. So
But
that's
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 more,
one we're doing. Yeah,
that's
for sure.
relationship building. That's marketing. That's not, you're not sitting down going through a list of patients and what those patients
No,
are doing.
correct. No, you're right. No.
Yeah. Okay, and then last one, and I think this is the most important one: patient satisfaction with a specific PT, whether it be an individual human or a physical therapy practice. Um, you guys have heard it 100 times. My differentiating factors, my claim to fame: I will never send your patients back to you worse than they came to me. I will never have a surprise bill arrive in your patient's mailbox that's going to make them upset, and I'll get your patients in today or tomorrow. As soon as they call me, I'll get them in within 24 hours. Like, those are my marketing efforts, because I understand the power of a satisfied patient, And so, what do you think? I think this is more important than my competence, is making my patients happy.
They are the judge and jury, so they absolutely have to be satisfied. You could ask those things. Some patients might feel uneasy and they don't want to tell you in person, like, oh, like your office is a little dirty, or this is too out of the way for me, or you guys are nice, but like I don't want to do this, whatever. You have to try to dig and find out for sure, like, are they actually truly happy? They're gonna. I think it's kind of typically easy to find like peak of happiness, or are they actually satisfied or not, because they're going to say like, oh my god, I love this tone, I can't wait to come back, or they're writing us Google reviews. Their patients are texting me like, oh, Dr. Mo and Porus and Dr. Chris, like they're great, and then I'm saying to them like, hey, can you put that in a Google review and post it? And then they do. So like those are the things for us that are some checkpoints of like patient satisfaction. I mean, one of the easiest ones is like, does someone continue to book and schedule and use the service and refer you to other people? And the ones that don't, there's obviously something. It might not even be you. It might not be us. It might be them. They might
Yeah.
be going through a divorce. They got fired at work and they don't want to tell you because they're embarrassed. Like you could try to dig, I think sometimes, and sometimes it's just some personal things that you might not even know about.
That was the hardest lesson I learned as a young physical therapist, a new grad, was I would be working with somebody, I think they're doing amazing, and they're like rude to me, and they're not loving it, and they're not praising me the way everybody else praises me. And of course, you get obsessive about it and you're like, what in the heck? It has nothing to do with me. It is their insecurity. And this is the truth. This is one of the things that changed my initial evaluation process. Um, I was that therapist, and I bet a lot of the guys on here, the women on here, you're probably still doing this. I was that physical therapist that loved to show patients how out of shape they are, how weak they are, how tender these painful spots are. Find all of these little nuances that other therapists might have overlooked, because it made me feel good. It made me feel smart. And I thought it would impress the patient. Then I found out, you know what? I'm making the patient feel like crap. I'm making the patient feel insecure, and like they've neglected their body for 40 years, and I'm shaming them for all of this stuff. And I had no idea, because we geek out on it. We're like, oh, look at that gait pattern and the hip and the knee. And well, patients don't want to feel bad. They're coming to you to feel better emotionally, psychologically, physically. So you guys hear me say, I do a 10, 15, maybe 20 minutes. 20 minutes is a long evaluation for me. You think Tony's a terrible therapist. It's not about that. Like, I understand, I learned the stuff that you guys learned, but in 10 minutes, I can make somebody feel better and get a win under their belt. And then they can leave feeling like $1,000,000. And then they come back tomorrow or the next day and the next day and the next day. And, that is the approach. That's the context around why I do what I do. And the truth is, we can tell at this point, 20 years in, okay, this is something serious that needs deeper investigation, or this is like 100 other situations. It'll get better with time. Let's just get this person feeling good. So that's my parting shot. I'm going to end it with that. Dave, what's your parting shot?
Man, I can't beat that. It's a great parting shot. I'll say the reminder around what to say, what not to say during an evaluation, especially now with costs being more, deductibles, premiums, all that being more, people are more likely to pay out of pocket, or they're having to pay more out of pocket to cover your costs, or maybe you're doing out of pocket services wherever you are in the country listening. The calls, the conversations, the interactions, all that they have to evolve, they have to improve, they have to be different, they have to be focused around the patient, they have to be focused around their goals, not your modalities and your doodads and your therapeutic skills and all that. So that's my parting shot.
All right, guys. Today was a short session. Come back on Tuesday, Thursday, every morning, 8:30 a.m. Eastern. Dave and I will be here, PT Breakfast Club. I'll catch you guys next time. Go Birds.
Go Birds.